Okay, welcome to RxPerience. This is the Midsummer Night's Dream grab bag episode with your host Chad and Tom. And if you've been working in long-term care pharmacy or senior care pharmacy at all in 2025, grab bag doesn't seem like such a bad topic. Every day we wake up to something new that we have to deal with. Recently, we woke up to RFK Jr. firing all of the people on the advisory committee for immunization practice and apparently going to reappoint all of them for a meeting that's going to dictate, what our process is and what our recommendations are going to be in the fall. So that's the latest. Latest thing that happened.
But not super surprising. I mean, he's been on an anti-vaccine tour for 15 years or however long. He certainly has had a lot of, comments against that industry and against that practice of vaccination. And, that's the thing about any medication or any statistic. There's some truth to it.
Sure.
But, then they take a statistic. And I was once told by a boss of mine, he said, or it's actually a CFO, he said, there's three types of lies: damn lies, and statistics.
Yep.
So any one of those, like, I can make numbers do whatever I want to do. And it just seems like when you start getting into something like this, especially it's political, the numbers seem to tell a story, and then you research a little bit more and you get a complete conflicting conversation.
Yeah. I mean, the vitriol that comes out, against one side or the other is always, the knee-jerk reaction is, all right, we're going to send a letter and we're going to say how much we hate what just happened. And I think you have to take a step back and say, okay, we had some problems with ACIP from our perspective. They didn't have enough people that had geriatric backgrounds. They didn't have enough pharmacists on the committee. Does that mean you should gut the whole thing and start over? And does that mean that we're going to get some geriatricians or some pharmacists on the committee? No, but we have to look at everything from the perspective of, okay, we're used to this chaos routine. How do we influence what it becomes so that we can make sure that, the people that we're caring for have the best information available to them? So, we'll see what happens. Hopefully there are some, pharmacists gave most of the COVID vaccines. Pharmacists are obviously heavily involved in vaccination efforts across the board. There should be some good pharmacists on ACIP. So we'll see if that happens. There should be geriatrics on ACIP because this is the population. Even prior to this, the recommendations out of the administration, out of RFK's office have been, if you're over 65 or you have complex medical needs, you should get the COVID vaccine. So, we anticipate nothing really changes in our world from that perspective. But we'll see. We'll see what happens.
Yeah, it's kind of one of those things like Pepsi Cola or something, Diet Pepsi, and people saying, oh, the saccharin and it's going to kill rats and so it's going to kill humans. But, Diet Coke has been around for 60 years, 70 years, and it just really hasn't proven to do that. And, when it comes to vaccines, it's proven that vaccines work. Vaccines prevent disease and wipes out viruses. But, does that mean all vaccines work for all ages? Well, no. I think there's certainly, a lot more studies that need to be done. But I'm worried that RFK is going to go to the full extreme from one to another, where now no vaccines for anyone at all, and for any reason.
Yeah, and I don't know, like you, I don't think he's going to do that. I think as pharmacists that work with older adults, we can recognize that you should be tailoring your medication profile to the individual, and that shouldn't be any different from a vaccine perspective. There are certainly vaccines that older adults should be getting, even if younger adults shouldn't be getting them or don't need to get them. We're used to that. So let's just make sure that we have the right recommendations. We're trying to protect a vulnerable group. I think the more controversial topic is, what do you do with the healthcare worker? If they're younger and it's not recommended they get the vaccine, should they be getting the vaccine if they're going to be in an environment where they're around vulnerable people, whether that's an
Right.
intensive care unit or a nursing home. So,
Yeah.
we'll see what happens there.
Especially when you have slim staff like in a nursing home. It's already hard to staff that. We got agency nurses and things like that just because of a certain area that you can't get a lot of qualified people, and then you mandate that they get a COVID vaccine, and they have a either a personal or religious view against that, and they don't want to do that, and now they're just not going to work at your nursing home, and now you can't provide care because of that.
Yeah. So that kind of dovetails into, we've been doing, Tom and I have been running around all the different vendor shows and long-term care and long-term care pharmacy shows, doing various speaking and panels and all kinds of things. And the only reason I tie it together is because vaccines are going to remain a mainstay for our population, the ones that our pharmacists work with, those that are medically complex and older adults. It is an opportunity to fight back against the bigger problem that's out there, which is overall pharmacy reimbursement. So, a good vaccine program can be a revenue driver for a pharmacy. It's not going to solve all your problems, but it's going to, start to plug the leaks in the wall of revenue as the leaks start popping through. And we've had the insulin problem. I'll tell you a story about that. We had the inhalers. Now they're priced so low that what used to be something that helped a pharmacy sustain itself no longer does that.
Yeah.
And then of course you've got the impending IRA drugs.
1,000-pound gorilla coming.
Yeah, I mean,
Yeah.
and how is it going to work? We're still not 100% clear how plans are going to pay pharmacy for those drugs. We have some, hopeful information that it sounds like they're going to pay the manufacturer, the Medicare negotiated price plus a dispensing fee, which would be great, which I think is funny. It would be great. It's what they should be doing. It's the fair way to do it. But
Right.
that's some of that information coming out, at least for some of the plans, has been positive, not all of them. And then we have the whole manufacturing piece.
Right. I think this is a perfect opportunity to differentiate long-term care pharmacy from other pharmacies. And we've been trying to do that in regulations for years.
Sure.
But here's another opportunity where if you're going to assess a dispensing fee, obviously it's going to be different for a long-term care pharmacy. They have a lot more operational costs than maybe a retail pharmacy. And just to get that definition of this doesn't apply to this group right here, or this group right here is reimbursement at a different rate because their costs are so much higher.
Yeah.
That with vaccines and all these things kind of happening. Also, Trump made some kind of tweet like 3 or 4 weeks ago that said, I'm going to drop prescription drugs across the world by 70%.
Yeah.
Across America by 70%, just some random, number that was selected. But, cost of prescriptions is the one of the top subjects that's, politicians are looking to get approval on.
Yeah.
And hopefully that's a very, across the aisle type of agreement when it comes to reimbursement. But, I had, like you said, we were at a conference and I had multiple people come up to me and go, what do you think is going to happen with, what do you think, how that's going to affect, or tariffs, and tariffs on China, and how's it going to affect us? And everybody's very, very concerned about the what ifs. But, the silver lining is long-term care actually might for the first time ever be differentiated from other pharmacy practices.
Yeah, it's possible. And I think we have to keep it in perspective in all pharmacy, but there's nothing wrong with a structure that says for these drugs, these Medicare negotiated drugs, plans should pay the Medicare negotiated price plus a dispensing fee. That doesn't mean that dispensing fee doesn't have to be different from community to long-term care based on service levels. That seems reasonable. And then from the manufacturer's perspective, paying that refund amount of WAC minus MFP plus some sort of administrative handling fee, plus some sort of, I don't know what to call it, professional fee that probably favors long-term care, because long-term care has done things like create formularies, make sure that people have access to the medications they need, because you're dealing with a predominantly older adult population that has drug interaction problems, has renal problems. There are reasons for them to move to medications that fit their profile better, and they should be rewarded for that, like they've always been rewarded for that. That doesn't mean don't pay community pharmacy if they can demonstrate that. Great,
Absolutely.
but that
Or doing
structure,
compliance packaging and other operational
yeah, that
benefits.
structure
Yeah.
should be standard. Now, how you negotiate it, how good is your PSAO, your GPO at negotiating the fees and the percentage professional fees? That's their job. Getting it to the right structure so that pharmacy can survive is, all of our jobs.
Right. No, for sure. I mean, again, IRA, we've been talking about it for years. It's unbelievably, it's what, 6 months away. And,
Yeah.
we're going to get paid different on December 31st than we are going to January 1st. And it's going to be, a very dramatic change. I know there's some statistics and reports out there predicting something like a 23% reduction in profit margin
Yeah.
for pharmacies,
Yeah.
regardless of their size, regardless of anything, if nothing else changes. So direct hit, to that profit margin. And that's when we start talking to pharmacies about, well, we can't control that. We certainly, ASCAP's fighting for us, and that's why I tell people wherever I go, like, hey, there's volumes and numbers. You want our voice to be louder? All your pharmacists, all your technicians, everyone that that's in this industry should be an ASCP member, and it's very important because membership equals volume, and volume it gets us the platforms that we need to explain the impact it's going to have on seniors in our population. But with all that said, at the end of the day, other than supporting ASCAP, I really can't control it too much. What I need to concentrate on is how do I diversify my revenue? How do I get other revenue streams,
wins?
like
Yep.
vaccine clinics, like clinical billing, and long-term care at home is a hot topic. Everybody's talking about it. Very few people are doing it well, but everyone's wanting to do it.
Yeah, and you got to look at the cost side of that equation too. Is automation a benefit? Is AI a benefit to helping you reduce your cost because you're faced with these declining margins? I mean, pharmacy's got to be looking at all of it. And I'm not going to say that long-term care pharmacy got lazy, because I don't think they ever got lazy, but I feel like we used to do more active utilization management than we've done recently, and they have to get back to that. And maybe there is another tier of operational efficiency that we need to move to also, whether that's, again, automation or AI or both. I think that it's pushing us to another tier.
It's all the above, and that I do have direct control over.
Yeah.
Controlling my cost to fill.
Sure.
If I can lower my cost to fill by 20%, 30%, 50%, and I think it's very, very possible. I've been in several pharmacies that have cutting edge technology out there that is, doing a lot of robotic processes and AI, and they just are not remaining dependent upon labor.
Yep.
And labor is hard to come by anyway. I mean, the cost of labor has went up, turnover has went up significantly over the past 5-6 years due to inflation and economic challenges and that kind of stuff. I just can't keep, every time I grow, I have to add 20% more staff, or whatever it is. It's not really sustainable future, especially my reimbursement's not going to grow unless I add more, more prescriptions and more patients, which is also not easy to do.
Yeah. I mean, when I think about this industry, ASCP is 55 years old. We can argue that's been the birth and the progression of the whole industry in long-term care pharmacy. It's always been about the pharmacy making more efficient the ordering, receiving, storage, handling, administration piece, as well as the clinical piece of utilization management. Those are the two arms of long-term care pharmacy. Both of those have to be focused on and made more efficient and made better from a pharmacy perspective if we're going to survive. I mean, both of those have to be worked on continuously.
And we need to not apologize for making a profit and
100%.
making money. We were the most trusted. I don't know if that's still the case, but we were the most trusted profession most of my, adult life. And, I think that if anything, I don't think we were complacent or lazy. I think we were too nice. I
Yeah.
think we were just a little too passive and kind of just, allowed ourselves to, kind of take what's left over or take the scraps off the doctor's tables, if you will. And, now there is a resurgence in being able to be a true, provider. I know that ASCAP spends a good amount of time on fighting for provider status for pharmacy, and I know you have some hopes that that's going to actually happen. Something could potentially happen this year.
I hope so. It's not looking great, but we'll see. And I think there are a number of things that we want to see happen. ECAPS being the provider status for test, treat, vaccinate's one. PBM reform is one. Some continued flexibilities in telehealth is another. All those things impact the revenue opportunity for pharmacies, and we need that. Some of the other things I think would be nice to see happen is, the Congressional Budget Office being able to score legislation dynamically, meaning they can count the savings created. Right now, and even with ECAPS, it's, well, how much is this going to cost us? And that's what the cost of the bill is. It's not how much is it going to save us. They're not allowed to incorporate that. So that would be nice. And then maybe sort of an outlier that people don't think about is the idea that a plan or a pharmacy benefit manager should not be able to own a pharmacy. I think that's a big one. And it's given me different perspective to the whole CVS Omnicare piece. Because I was always like, wow, CVS bought Omnicare. They didn't know what they were doing. They basically crashed it. But maybe that was the plan. Maybe the plan was, yeah, we're going to buy this pharmacy and we're not going to let it be profitable because we're sucking all that profit out on the Express Scripts side, on the CVS, Caremark side. And maybe that's what they did. And, as Optum buys pharmacies in long-term care, maybe that's what their plan is. Like, we're not going to reimburse even ourselves very well because we don't care. We're making the money at this umbrella level, we don't care here. And we're going to bleed out everybody else down here by the way we reimburse pharmacy. So now I'm more concerned about things like that whole vertical and, gaming the system.
Yeah. I mean, nothing prevents it. I hope that's not true, but at the end of the day, as pharmacists, it should be patient care and providing the best quality care and then making sure that's sustainable.
Sure.
And, no one, when it comes to long-term care and elderly, do a better job, obviously, than long-term care pharmacists. That's our area, that's our niche of expertise. But if we can't sustain pharmacies and they all have to become corporatized or centralized, and now all of a sudden you lose that, that extra touch, and I understand that during a crisis like COVID, you might be able to do a Teams call or a Zoom call and do some electronic clinical assessment. But boy, nothing takes the place of that pharmacist walking down the hallways, talking to the nurses, getting the real truth, observing the patients, seeing how they're reacting, and talking to family members. And you just can't replace that over Zoom.
No, and that gets to the whole relationship question. Like, we've cut relationship out of healthcare. Most people don't have a relationship with their primary care physician or nurse practitioner. Most people are losing their connection to their local pharmacist. I think, the real negative side, if you follow the path in long-term care, is, do you lose the relationship? Does it become so corporate where now the relationship between the pharmacy and the administrator of that nursing home is not important anymore? Like, those decisions are beyond, our pay grades.
Business.
It's all transactional.
Yeah.
And then you lose all of those pieces that you just talked about. You lose that, I'm going to get this med to you because, not only are we business partners, but we're friends and you need it and that patient needs it. Now that's not our company policy. We don't do that. You know what I mean?
Yeah.
It's just...
Nothing against Amazon, but they're a supplier, that they're a distributor, they're a supplier. It's not, I don't want to talk poorly about, their clinical insights and those type of things, but for the most part, they're a mail order pharmacy. They're supplying, or, I shouldn't pick on Amazon, but any mail order pharmacy is they're just sending a product. They don't really care really so much about what that product is. But I've got a friend who has chronic pain and has to go and is on regular, C2 medications to treat their chronic pain, and they have to go every month and kind of check in.
Mhm.
Their office visit, which they're required to do every month or every other month, their office visit, I'd say, can be summarized in about 5 minutes. They come in, they take their urine test, they do a Zoom call with the PA who's sitting wherever, Detroit or whatever,
Yeah.
and ask questions that are on the PA's checklist. Check, check, check. All done. Thanks. Bye.
Yeah.
And they're just churning them out
Yeah.
like some kind of plant or manufacturing plant. And it's just like, this is healthcare today.
Yeah,
This
right.
is who we are now.
Yeah.
And they're getting their paycheck. They're good. They're probably seeing, 18 people an hour, and they're churning them through.
Yep. Problematic.
Obviously don't want pharmacy to go that way, but providers, the people that's paying for things, they want the most cost effective, not necessarily the best outcomes even.
Yeah. I think if I gave a presentation at Red Sales Connect meeting, and it was with NCPA, and it was a panel discussion on the requirements for long-term care pharmacy at home, which is what we call it. And at the end of the day, it's really a higher level of service, pharmacy service for medically complex or older adult individuals in their house versus in the nursing home. It's not a club. It's, are you willing to be available 24/7? Are you willing to commit pharmacists to do medication regimen reviews? Are you willing to package in the packaging style that the patient needs to be compliant and adherent? Basically, are you willing to support somebody that has a lot of medication needs and doesn't want to go to assisted living or nursing home?
Right.
And then are the payers willing to pay for it? Like, you can't just do it. Are the payers willing to pay for it? But sometimes it's funny. The questions you get are, we tend to focus on ourselves too much. Like, the pharmacists were like, well, do you think the long-term care pharmacies are going to try to get this business? And I'm like, you've got 20 million people coming in this population that aren't here today.
Yeah, in 5 years.
In 5 years. Like, long-term care will start playing in this space because there's going to be very complex individuals that might require IV medications, might require 7-day fills, 14-day fills because of the changes in their medications. They just might be more acute, just like they service these more acute nursing home residents today. They're probably going to take that at-home population and focus on those more acute people. Maybe the people that transition out of the nursing home back to home. Maybe that's some of the people that they, but no, they're not going to come and take all of it. Amazon's not going to come and take all of it. Like, there's so many people out there to serve. Everybody's going to, fall into their comfort level. Everybody being the pharmacy is going to fall into their comfort level. Certainly community pharmacy is going to play a significant role in that. And they should be reimbursed appropriately if they're providing those extended services.
Additional services. Right.
But I think we worry about that too much. Let's just band together and make sure that we have a good marketplace for our services. And then, let the pharmacies find their water level, find their level.
Right.
Like, I'm comfortable when I'm taking care of somebody that looks a lot like a nursing home patient if I'm a long-term care pharmacy. Community pharmacy might be comfortable taking somebody that is a little bit more sophisticated than maybe the person that walks in their pharmacy, but they know them, they have a relationship, they know their habits. They can certainly service them better than even a long-term care pharmacy that, sort of appears out of nowhere in the public eye. So I think it all works itself out. I wish we would focus more on getting it done than who's going to take it from me if we do get it done. Like, can't worry about that.
Yeah, right. No, I mean, at the end of the day, it's not like 20 million people are just getting dumped on America. They're here now, and they're taking medications now.
Right.
They're just going to be taking more medications the older that they get, but their body's going to change and physiologically. And I would say most retail pharmacies focus on their drive-by or drive-in patients.
Yeah.
And most situations that I've seen, that don't have a lot of time for counseling, they don't have a lot of time. They're trying to get that volume as well. That's how they're keeping their doors open. And so when you talk about a patient that is really qualified as a long-term care that's happened to reside at home, they need a whole lot of extra TLC that typically that independent pharmacy is not just doesn't even have time or resources to really provide the needs that patient needs, and they're going to continue getting older and needing. I was actually at that talk. I was sitting in the back row. I was heckling you, but it was too far away, so I don't think you could hear me.
I couldn't see
yeah,
it.
you and Becky, it was great because one of the questions I was waiting when we come to Q&A time, they had lots of questions at the
They
end,
did.
but you guys did a very, very thorough job of kind of step one, step two, step three, and you went through the entire plan. But I was waiting for that. Which PBMs are actually paying high
Right,
reimbursement?
right.
That was right off the bat, and I knew that question was going to come out because there are a few that have, been trying to compete with the bigger PBMs that they've, recognized that, and they're trying to differentiate themselves. But, it's more than just compliance packaging, even though I
Sure.
think that's
Yeah.
critical. Why do compliance packaging and I deliver? So am I qualified for long-term care? Well,
Not
no, not
necessarily.
exactly. I
No.
mean, it would be nice if it was just, do these two things and, get higher reimbursement. I'm sure that most people want to take the easy way out, but there's an assessment portion.
Yeah.
And that's not a one and done. That patient, as they get older and their health changes and their disease state changes and they're in and out of the hospital, you need to continue to assess every month. You continue to ask them the right questions. You need to do a very thorough job of, looking at their diet and looking at their environment. And it takes a lot of extra work, but it is volume. And there is 65 million people now, going to be 75 million people in 5 years that need deserve
Yeah.
that extra care, especially if they don't have a caregiver living with them or a family member living with them.
Yeah. I think I also believe that water finds its own level too. There will come a tipping point where the plan recognizes that, hey, if I don't pay for that service and that patient doesn't get that service, they are gonna advance into a higher costly level of care. Maybe we need to help them make those connections faster, but there will come a point where even the plan recognizes, well, I can keep having this person get amber vials from the local pharmacy, but they're going to crash and end up in the hospital or a nursing home, and then they're going to be a whole lot more expensive to me than they are now. So they're going to recognize those services are helpful.
What's interesting is years ago, CMS came out with value-based outcomes, and
Yeah.
they dinged the nursing home for rehospitalizations, not
Yeah.
just reputation and five-star wise, but also financially, and it forced a reaction.
Yep.
And I'm assuming that overall, since that went in place, whatever, 8, 10 years ago, that there's less rehospitalizations, that more nursing homes are more aware, they're taking more measures to prevent rehospitalizations. But it is post 90 days of that hospitalization, and that's kind of it, and they're assumed to be out on their own. But it'd be interesting if there was some kind of, not necessarily catch you doing wrong, but some kind of incentive to say, hey, if a pharmacy takes responsibility to avoid rehospitalizations and for outcomes, we'll pay you X to avoid that. I think you'd have pharmacies lining up, volunteering to go, man, I'll do better. I'll do assessment. I'll deliver. I'll do a lot of things to help that patient stay out of the hospital. And I think it would just take one act from CMS to find a way to, encourage ownership of that patient's health.
Yep.
In addition, and I think people would line up to do it. Home health companies, certainly, home care and pharmacies.
Yeah, and maybe that's a future topic for one of our podcasts, is to bring some people in from PACE so that we can, because I think honestly, PACE probably has a lot of answers to some of our questions. I don't know that, I'm sure they publish their outcomes and how their system works, but there's probably a lot of learning that long-term care pharmacies and people servicing long-term care patients at home could glean from looking at how a PACE operates, because they're so, they have to be value-based because they're capitated. So they do things, to make sure that patient doesn't end up in the
Go to
hospital
the
or a
hospital or
nursing
go to a
home.
nursing home. Yep.
So what do their
Yep.
utilization patterns look like? What does their compliance packaging look like? When do they make the cutoff of, hey, this person needs this or this, whatever that intervention is? Those things would be, I think, invaluable to pharmacies that are starting to work with patients in their home. They might pick up some tips and some strategies that ultimately have some evidence behind them. So
It's a good call out, and they're surprising. I haven't heard of non-success stories in PACE. Everything seems to be successful for the patient, for the provider, even for the pharmacies that are working with the PACE programs. But a strikingly small number of people that have been approved. It's almost like a slow resistance, a very long curve. But yeah,
well,
I don't know if there's any model outside of the hospital that's proven to be more successful, but you're still talking, you
yeah.
know, 20 states don't have a PACE program.
Yep.
This, 10, 15 states have one or two small programs. It's almost like they're still testing it out, but
Well,
I think it's proven to be successful.
it's politicized like everything else. The detractors will say you're cherry picking healthy people and you're putting them in PACE and you're saying, wow, look how great they did, but they were not the nursing home train wreck patients that we anticipated that PACE would take. And then the people on the other side are like, no, these are nursing home patients and they were train wrecks and we put them in PACE and it all worked out better. Like you just have that constant battle. I think in looking at the data, we could probably glean out where that might be happening in PACE and really get to the core of what works. And then again, those core strategies should be influential on the rest of healthcare. Whether or not that means more PACE or not, there's certainly things we can learn.
Yeah, similar type of programs.
Yeah.
I mean, I would think Medicaid finds that to be a win. The states that have done that, they find that to be a win for their budget.
All right. Well, good Midsummer Night's Grab Bag Dream episode, Tom.
Yeah.
Nice job. We can do it without a guest, can't we?
Sometimes we make it through.
And we didn't even talk about Trey Hendrickson or TJ Watt yet.
No. We'll save that for in December, but we're mid-season baseball, getting near to the All-Star break, 4th of July. Any predictions for how this baseball season is going to end?
I don't know. I mean, Dodgers and the Yankees have spent the most money. You kind of assume that they're going to be in the argument at the end. You like to hope that there are some upstart small market teams that scrap their way in. We'll see. My Reds are 500-ish, so I'm not all that positive.
Don't complain. I've been a lifelong Pirate fan. We're a AAA farm club. We just get players and make them good, and then trade them off or sell them off. Yeah. So.
All right. Well, good summer. We'll see everybody next time on RxPerience.